I would like to thank organizers for giving this opportunity, and I will be talking about the role of adjuvant chemotherapy in early stage lung cancer. So as my dear colleague has spoken about, as we move from the early stage to the advanced stage, the 5-year survival drastically reduces, and when we look at the relapse rate, the distant failures are more common as compared to the local failures. So after the surgery, almost more than 80% of the relapses, they occur within 2 years after the surgery in the post-operative period. So we need some kind of very systemic therapy just to prevent these distance relapses to be happening. So before 2000, many of the trials were carried out, but they had very small sample size, as well as there were methodological flaws that prevented them from drawing any clear-cut conclusions. And that also led to some of the nihilistic attitude towards the chemotherapy development. So this was the first paper which was published in the BMJ in 1995 as a meta-analysis, and which has studied some of the agent. While the alkylators had a detrimental effect on the survival, cisplatin-based treatment showed one of the improvement in the survival, but the difference was not statistically significant. There were some of the flaws related to this meta-analysis as well, like the small sample size. Patient had a very significant surgery with related to the thoracotomy and delayed post-op recoveries, as well as at that time the supportive measures were suboptimal, like use of the antiemetic or the GCSF, as well as poor compliance to the chemotherapy. So this was before this trial. There was another trial called as ALPI, Adjuvant Lung Cancer Project, which was the first reported and the last negative trial to be published. Although it did not show any improvement, but that led to the foundation of the further chemotherapy trials in the adjuvant setting. So this is an international adjuvant lung cancer trial collaborative group, cisplatin-based adjuvant chemotherapy, and this was the first study which showed a significant improvement in the outcome as compared to the PFS as well as the overall survival. It included the good number of almost 1800 patients, and the chemotherapy related deaths were 0.8% only. So this trial basically led to the clinical implementation of adjuvant chemotherapy in the practice. As we can see, particularly node positive patient and the stage 2, stage 3 patient benefited from this trial particularly. So apart from that, this was a JBR10 trial which studied the effect of the adjuvant vinorelbine and cisplatin on the survival. They studied stage 1B and the stage 2 patient. Although there was no benefit across the 1B patient, but the stage 2 patient, there was a doubling of the median survival with a significant hazard ratio of 0.59. Apart from that, this was a ANITA trial which has been very well known, and it established the role of the adjuvant chemotherapy as compared to the observation alone in the post-op patient. So this trial had a median follow-up of almost 76 months, and it showed a median survival 5-year OS improvement of almost 8.6%, and the absolute benefit was also very great. So it showed both improvement in the DFS as well as the overall survival. From this trial, although stage 1 it was a detrimental, but stage 2 and stage 3A patient benefited the most. So apart from that, particularly for stage 1B patient, this was a CALGB trial which was carried out. So they again studied the outcomes related to the use of the chemotherapy in particular subset of the population, which was doubtful. So in the subgroup analysis, they found it out that those tumor more than 4 centimeter, they would have the improvement in the outcome, but not the other patients. So apart from because of the heterogeneity among the trials, many of the efforts were carried out to find it out a meta-analysis to combine all these results together. And this was the first meta-analysis that has been having a very important thing. So this was a LACE meta-analysis which pulled the individual patient data from the 5 studies which were main studies like ANITA trial, JBR10 and the related trials. And this trial had shown that 5 years absolute benefit of 5.4%, while at 5 years the lung cancer death was reduced by 6.9%, while the non-cancer related deaths were increased by 1.4%. So again, it showed an improvement in the DFS as well as the overall survival. Some of the important feature for this trial, because of the meta-analysis, there was no heterogeneity of the chemotherapy effect, and it results benefited most of the patient from the stage 2 onward, and the drug which was given in combination with the cisplatin did not modify the effect of the chemotherapy, and particularly the effect of the chemotherapy were better in those who are having a good performance status. So this was again based upon this particular meta-analysis. This was an editorial comment on JBR10 study which was published in NEJM 2005, mentioning the result as astonishing because it was almost 2 decades of the research. So this is the meta-analysis showing the benefit with stage 2 and the stage 3 patient. Absolute benefit also more pronounced with this particular patient as well. So later on, there was one controversy came up whether the effect of the chemotherapy started fading as the time progresses, because from the IILT trial, it was seen that the benefits were not maintained beyond the 5 years. But when it was actually studied, it was increased. It was not due to the decrease in the anti-tumor efficacy, but more due to the increase in the non-tumor related deaths. But subsequently, with the JBR10 and the ANITA trial, long-term benefits were seen. So coming toward the toxicity encountered with the chemotherapy, even these are the original trials, we can see the incidence of the neutropenia as well as the CINV as a prominent things. But as we know that with the recent use of the supportive cares, I feel this incidence nowadays has gone down drastically. Apart from that, most of the patients were able to complete the planned number of the cycles. So earlier, whether the compliance related to the chemotherapy was proper or not, that was one thing. Initial trials has shown a compliance ranging from 50 to 70%, but in an audit, when the positive results were published, those trials have shown the compliance of almost 80%. Thus, it shows a positive effect of patient as well as the doctors towards the chemotherapy adaptation. Coming toward the long-term adverse event, with the exception of the sensory neuropathy and the hearing loss, rest of the side effects were manageable, they recovered, and the quality of our life also returned to the baseline by 9 months after the treatment. There was no adverse impact on the pulmonary function. This was a quality of life as well as it was assessed from the JBR10 trial. It showed a transient worsening of the quality of life, but almost it resolved by the 9 months except few of the adverse event. So coming toward the role of the pemetrexed use in the non-squamous histology, these were the various phase 2 feasibility studies which has shown some of the improvements in the outcome as compared to the other regimen. So this was a GPANG study which studied the role of the pemetrexed in this particular patient. Cisplatin with pemetrexed was compared to the cisplatin and vinorelbine, and it showed that this pemetrexed based chemotherapy would be having an equivalent result, but it will be again having the better tolerability and better side effect profile, and hence the pemetrexed remains the standard of the care. Even if we see the NCCN guidelines, so they would advise testing for some of the mutations like EGFR and the PDL1. So the cisplatin and the pemetrexed for the non-squamous histologies, while the gemcitabine and the cisplatin remains for a squamous histology. Apart from that, there remains option of the vinorelbine as well as the etoposide, and maybe those patients who are not able to tolerate the cisplatin, carboplatin can be combined. Apart from that, some of the adjuvant setting like EGFR and the use of the immunotherapy, but with the osimertinib from the IDURA as well, many of the patient, the criteria is a patient has to complete the adjuvant chemotherapy, or patient might, if patient is not eligible for the chemotherapy, then we can escape and use the adjuvant treatment. So maybe this topic will be covered in the subsequent talks. Thank you.